I was asked to look at some of the highest spending providers ACO wide, and the first two slides shows who I looked at, and the three areas that I looked at was their high needs patients, potentially preventable services, and then potentially preventable visits. And then I also did look at their VIS score just to see if that had anything to do with cost or not. And I did notice that these providers were lower VIS score versus providers that were not the high spenders. And then some of the services that I noticed that a lot of these providers had were a lot of ER visits, chiropractor visits, independent lab. And when I looked at that to see what that really meant, one of the labs that I recognized when I was at family practice was something that they sent on to Good Sam and then was sent on to Mayo's. Now, I don't know what all the different clinics do for in-house lab versus what they send out, so I don't know if that's every scenario, but that was one thing that I noticed when I did look at one of the providers at family practice. A lot of radiology. There was one patient that had gone to several different ERs within 1 month, and they had the same scan at both ERs. Diabetic sores, pressure ulcers, wound treatment being done at a hospital setting versus in the clinic. DME supplies, a lot was for sleep apnea. And then office visits for specialists at the hospital versus freestanding clinic. So, for example, a cardiologist going from like Kearney or Lincoln or Omaha to one of the smaller towns and seeing patients at the hospital at an outpatient setting versus seeing them in their main clinic in Lincoln, Omaha, Kearney, Grand Island, wherever. And then the same thing for physical therapy. There was a lot of physical therapy on the outpatient tab versus the professional tab. And so my question to Blue Cross, and we're still waiting to hear back, is does the physical therapy at the hospital and office visits at the hospital cost more than their freestanding clinic? My guess is going to be yes, but I don't know that for sure. So what is a potentially preventable service? It's an ancillary service that is ordered by a primary care doctor or specialist in an ambulatory care setting that may not need to be needed to treat that diagnosis. It does not count if it's an inpatient setting. And some of the common potentially preventable services, according to TREO, is these listed here. I did notice chiropractor's not on here, but that is one that I did see repeatedly. And then another one was potentially preventable visits, which is ER visits that could have or should have been avoided if they had proper, or not proper necessarily, but adequate patient monitoring and follow-up in the office. And a lot of the diagnoses that they see with this are listed here, and I do see a lot of migraines, stomach pain when I look into these visits. A BIS score is made up of 6 main components, and then each of those have been broken down into 16 different measures. Blue Cross had told me about a year ago that a BIS score of 50% or lower is someone that we need to focus on. The goal is 75% or higher, and I've always looked at this as like a performance goal. The first section is looking at breast cancer screenings, colon cancer screenings, well visits for children. And then the next one is potentially preventable admissions and ER visits. And then continuation of care. And I had a question on that yesterday, what this one really meant. And so I did email Blue Cross to get this one described a little more in detail, and I am waiting to hear back on that. Chronic and follow-up care is potentially preventable readmissions in 30 days, provider office visit within 30 days of post-discharge, and chronic patients with 3 provider visits. And then population health is members with chronic conditions and then conditions that do not increase in severity. And the last one is generic prescribing and potentially preventable services. So where to go to find this information? The VIS score, you have to have access to the budget side. The potentially preventable services and the potentially preventable visits are on the population side. So you go to the dashboard. Here is the 2 sections for the preventable visits and preventable services. You can click on member list over here and it'll download all of your members that have had the potentially preventable services or visits, and just start going through those. Look to see if it is something that you guys can prevent. If they are going to the physical therapist way more than what they need to for their post-surgery for their shoulder, or are they going to the chiropractor? I've seen 50, 60 visits in a 12-month time. Is that something that they could come into the office and have something treated for because they're not getting relief at the chiropractor? One thing you can do is add those diagnoses that the cardiologist is seeing them for that you may not have in your chart, or these diagnoses that they are seeing the chiropractor for, or physical therapist for, and put per TREO. So then when your providers see the patient, they can see that they are seeing somebody else, and this is what they're being seen for, and this is how many times they've seen that person. This is what it looks like when you download that member list. You can export all, this is for the whole ACO, so you can export it and have a whole list and sort through that way. Or you can go over here to search and put a patient's name in and see if they're on this list. This is the first window that pops up when you click into a patient. This is the professional visit history. So this is where you will see the physical therapy, the office visits from those specialists, or the occupational therapy if they're being done at a freestanding clinic versus the hospital. This is chiropractic care. This is what it looks like when they're on the outpatient tab. So this is where I was seeing the office visits at the hospital, the physical therapy at the hospital. Here's one they had a DEXA scan at the hospital versus in your clinic. Where to find the VIS? This is at the clear bottom of the dashboard when you are on the budget side. If you want to see individual providers, click on this 49.6. At your clinic, it's going to be a different number, and it will take you to each of your providers. And then to see if you have someone that is below 50 and you want to just focus in on one component like the population health or the chronic follow-up, click on that number and then it'll break you down like I break it down here like I have at the bottom and tell you exactly where they are the lowest. So one provider I was working with the other day, their lowest was the primary and secondary prevention, and they were doing okay on the mammogram and the colonoscopy, but their low point was the well child visits. So that's somewhere we could focus on with them, is the well child visits. Are they just seeing the ones that are scheduling appointments themselves, and we can maybe do some recall phone calls or letters, or exactly where those are falling through the slip at? Does anybody have any questions for me? For those of you that joined late, this is being recorded and I'll put it on Basecamp.
Heidi, how often is it? This is Dr. Michaels. How often is this updated for the clinics? Monthly?
Yes.
Usually by the end of the month for the month previously. So by the end of September for August, or how's it done?
August, it was updated August 18th. September was September 19th. So that's where it's kind of that late.
Okay.
Any other questions?
This is Dr. Michaels again. One observation I would make for those clinics who are on, if they're working with some of the MOC data with our maintenance of certification information, one of the steps that you could put into one of your evaluation and recommendations would be doing something with TREO to look at those and begin to see where you might have gaps in care in the diabetic arena. If you put that in actually as a step in your planning, that you're researching those, it becomes a valid step in terms of working through your plan to look at those. You do it, obviously, to get where the gaps are, but you need to think about also putting it in your planning activities for your processes where it fits the most efficiently, et cetera. But that's one more way that you can actually use the information that Heidi's presented today in another way. So we get, again, two things for one.
That tab that Dr. Michaels is talking about to see the gaps in care is this last one here.
In addition, I would say, which Heidi has pointed out, that for these that are PPS or PPV, part of your process would be, again, to consider taking steps to make sure that those people are actually where you have the preventive services, are they following up in your clinic appropriately? Or as some of my patients do, they say, well, I went to the ER, I shouldn't have to come see you. Or I had lab done at my specialist office, so I don't need an A1C. And obviously, if you're fortunate enough to have information from the specialist office, often they didn't do the A1C. They did whatever they were interested, but not what we need. Sounds like you've gotten you've gotten this all thoroughly oriented, and I don't hear any questions unless there's somebody saying something that I'm missing.
I'm not seeing anything on the chat box either. So if there's no questions, we can end, and I'll be posting this on Basecamp, and I did add a slide, so I'll send that additional slide out to everybody as well.